Thank you for joining today's webinar. So before I begin, again, for those of you who are out there, just a couple of technical issues. If you come across any problems with the sound or the webinar, please chat to our host, and you can find the chat bubble down on the bottom of your screen. And please, at the end of today's webinars, complete our brief survey to give us some ideas for topics you would like covered in this series or in the space that we're going to be working on in today, or any other topics you'd like us to address at the CTAC. Just a reminder, during the conversation today, you can chat in comments or questions to our panelist, Dr. Arthur Becker-Weidman. Dr. Becker-Weidman is also going to provide opportunities for you to ask questions during the course of today's webinar. But we'll compile any questions you have during the course of the presentation, and then we'll bring them back during Q&A at the very end. Thank you for joining us, and let's get started. So on behalf of the Community Technical Assistance Center of New York, it's my pleasure to welcome you to today's webinar, Dyadic Developmental Psychotherapy, an evidence-based developmental approach to treating complex trauma and disorders of attachment. My name is Dr. Jim Rodriguez, and I'm the Director of Trauma-Informed Services at the McSilver Institute for Poverty Policy and Research and the Community Technical Assistance Center of New York. This offering is part of a series that we're calling Big T, Little T. So in a recent offering in this series, we discussed high conflict parental separation and divorce as trauma. Today, we're going to be talking about attachment disruptions as trauma and other early forms of early childhood trauma that can obviously impact people over the course of their lives and obviously through childhood as well. You know, as clinicians, sometimes the more complicated issues among the people we serve, whether they're young children or youth, their families, as well as adults that we serve, oftentimes the most difficult and complicated issues are those with very severe histories of early childhood trauma and attachment challenges. So working with people impacted by attachment disruptions does require a lot of attention, certainly doing a thorough assessment, asking those questions about early childhood attachment and early development, as well as the tools to help individuals and families with histories of attachment problems recover and heal. So to provide information on assessment and more importantly, dyadic developmental psychotherapy, we're lucky to have Dr. Arthur Becker-Weidman. Dr. Becker-Weidman received his doctorate in human development from the University of Maryland Institute for Child Study. He achieved diplomat status from the American Board of Psychological Specialties in Child Psychology and Forensic Psychology. He's a member of the American College of Forensic Examiners, and he has received extensive training in dyadic developmental psychotherapy. And, you know, in discussing this offering with Dr. Becker-Weidman before, we also discussed, although Dr. Becker-Weidman's work specializes and works largely with adoptive and foster families, and I'm not sure if it's largely, but works with adoptive and foster families with children who've had serious attachment disruptions in their lives. He also shared that the assessment processes and the interventions we're going to be talking about today are also appropriate and effective for biological families or birth families with histories of attachment disruptions. So with all that said, I'm going to turn it over to Dr. Arthur Becker-Weidman.
Thank you, Jim. Welcome, everybody. So just a quick overview of what I'd like for us to be able to do today. I want to do a quick overview of assessment. And as Jim indicated, that's important. To be real blunt about it, to begin treatment without a thorough assessment, I think is a mistake because different conditions, as you know, have different evidence-based treatments. So I'm going to talk about that. But the bulk of the presentation will be about dyadic developmental psychotherapy, which is an evidence-based treatment for families, children, young adults who have experienced complex trauma or who meet the DSM-5 criteria for reactive attachment disorder. Now, some of what I'm going to talk about there can be used with other families and other situations, but I would describe that as an off-label use of DDP. Okay, just like your physician may prescribe a medication for you that's used for something else, but he or she has experience that is good for the thing you're presenting with, they're using that off-label, that's okay. That's, professionals can certainly do that. I will pause periodically to see if there are any particular questions or concerns, and I'll try to answer those as best I can. I will mention if we can avoid questions such as, I'm working with a family and the child does this and the parents do that, what should I do? And the reason for that, the answer to that, pretty much for me is always, well, it depends. And we'd need another 15 or 20 minutes for you to answer my questions about that before I could give a coherent and helpful answer. So what I will suggest, if you do have questions like that, you see at the bottom of the screen, there's my phone number. You can call me. If I don't pick up, leave a message. You can email me. I'm happy to chat and address those kind of specific case-related questions in that manner. Okay, so with that being said, I think the first thing I'd like to start with is you all, let's see, there we go. If I were to say to you, hey, I've got this 8-year-old boy I'd like to refer to your practice, and here are some of the behaviors that he presents according to his parents and teachers and what I have observed. And as you look at this list and think about the 8-year-old boy, you would be thinking, oh, Art's referring a kid to me who has what? And just put a few notes in the chat, and Jim can call out what some of the ones are. What would you think is going on with this child?
Sorry, Art. So folks are saying ADHD. Others? Yep, they're just coming in ADHD.
Right, and you would be right, because as you know, the DSM-5 is kind of like a Chinese menu. You pick 1 from column A and 3 from column B, and you got the lunch special. Or if you have 6 or more of these type symptoms, you meet criteria for ADHD. That's looking at symptoms, and that's making a diagnosis. What I want us to think about and talk about is assessment, which addresses why are we having or observing these behaviors, because we treat what's causing the behaviors, not necessarily the behaviors. Just like if you go to your family doctor with a cough, you don't want your doctor to say, here are some cough drops. You want to know, well, do I have COVID-19? Do I have an allergy? Do I have asthma? Do I have lung cancer? All of those present with a cough. So yes, this child technically meets the DSM-5 criteria for attention deficit hyperactivity disorder, but you could get the very same symptom profile if the child had an anxiety disorder, right? If the child had been prenatally exposed to alcohol, crack, meth, or other toxins, and had the brain damage associated with that, you could see these same behaviors. If the child had notable sensory integration difficulties, you could see the same bit of behaviors. If the child had suffered a traumatic brain injury, and each of those you would treat differently. That's why assessment is important. I'm being a little facetious now. Diagnosis is easy. Sometimes I think I could just hand the book to a family, they could thumb through it, and they could come up with the diagnosis. Our job is to answer the question, why, so we develop an appropriate treatment plan. And the assessment model I'm going to talk about, as Jim mentioned, really can be used with any type family. It's what I use in every situation. When I get a call from a family, I'm sure you get these calls, or you get a call from typically a mom, oh, I'd like my daughter to see you for counseling, right? We all get those calls. My response to that always is, I'm happy to help. I always begin with a thorough assessment. Here's what I say to the family. I always begin with a thorough assessment. First, I want to meet with you. And are you single, married, widowed, divorced, separated? If they have a partner. First, I want to meet with you and your partner. Send to me copies of any and all records that you have on your child, school records, individual educational plans, et cetera, et cetera. I'm going to mail to you a variety of tests and questionnaires for you to complete, maybe some for the child, depending on their age, and some for the school to complete and get back to me. I'm going to then meet with your child. That's interview number 2. And then after I get all those materials back, score the tests and questionnaires, there'll be a third meeting, you and your partner, where we'll go over the assessment. I'll talk about what I think is going on with your family, answer all your questions about that. And then in the second half of the meeting, we'll talk about what you do about it. Okay? That's what I do in every situation. Okay. Okay. On here. Here we go. Oops, too far ahead. So when we talk about evidence-based treatment, as I say here, that's an incomplete sentence. Evidence-based treatment for what? Okay. Dyadic Developmental Psychotherapy is an evidence-based treatment. If you go to the California Evidence-Based Clearinghouse for Child Welfare, you'll see it's listed there. I think it's level 3. There have been empirical studies, not, double-blind studies, but there have been empirical studies comparing this treatment with other treatments. Okay, so you need to ask evidence-based treatment for what? And if you're using it for a different population, that's fine, but then you're using it off-label. So for example, my older daughter, she's a clinical psychologist. Her research involved a 3-site, multi-site study, random assignment, looking at teenage depression, looking at CBT, medication, and both combined. And of course, what she found was both combined are the most effective treatment for teenagers with, significant depression. But to be in the study, obviously you had to be a teenager. You had to meet the DSM criteria for major depressive disorder and nothing else. So again, if I think about my own practice, I don't see many children, teenagers, who only have depression, or often other things going on as well. Does that mean you can't use medication and CBT for those kids? Yes, you can, but recognize that that particular child doesn't meet the sort of criteria used in developing the evidence base. So it's very important to go back to the foundational literature. And again, different treatments for different conditions. That's why we have to do an assessment. For example, EMDR is, has been shown to be effective for discrete traumas, right? For PTSD, you have occupational therapy for sensory integration issues, trauma-focused CBT for discrete traumas, CBT for anxiety, depression, et cetera, et cetera. So again, the list here is just to point out why we have to do a comprehensive assessment, okay? Okay, so overview of assessment. One of the things that I find, there we go. One of the things I find in doing assessments with children and families where there is a notable history of disrupted early attachments and complex trauma, for example, is those children often experience shame, overwhelming shame, not guilt. And I'm not going to belabor the point, but as you know, there's a big difference between shame and guilt. Remember Erik Erikson's stages. First, there's shame. Once you've worked through those toddler years about that, guilt. Shame is about who you are. You're bad, you're defective, you're unlovable. Guilt is about what you did. Shame is so uncomfortable as a feeling that people, in effect, develop strategies to defend against that. So I describe that as the shield against feeling shame. So one, little kid, a toddler may cover their face or turn their back, right? They do something they shouldn't. They notice, right? Kids are, inquisitive. They notice that this kind of thing would fit in those little, those little things by the baseboard. They've got two little holes, right? Electric outlets that would fit right in there. They go to do that. If you're a good enough parent, of course, you yell, stop, don't do that. Little kid may hide their face. Older kids and adults may hide by not telling the truth. Oh, no, I didn't do it. Or blaming others. No, my sister did it. Or getting angry. You're always blaming me. Why do you pick on me? Or, as you often see in teenagers, who cares? I don't care. It wasn't so bad. Yeah, I hit my brother, but there was no blood. Why are you so angry? Okay, so a comprehensive assessment should look at all of these issues, okay? All of these topics. You don't have to be an expert in them, but you do need to know enough to screen for them. So, for example, executive functions and neuropsychological issues. I'm not a neuropsychologist. I don't do neuropsychological testing, but I use the behavior rating inventory of executive function to screen for that. And if it's, if there are enough difficulties identified on the brief, then I might make a referral to a board-certified pediatric neuropsychologist. I use the sensory profile, for example, as a questionnaire to look at sensory issues. If I see enough of those as probable or definite difference, I would refer them to an occupational therapist for further evaluation. Okay, so you should at least touch on each of these areas. And when I write a report, I touch on each of these areas in the assessment portion of the report. Okay. It's up a little bit. Okay. So, other areas that need to be covered, as you may be familiar with, complex trauma, which refers to chronic early maltreatment that occurs within a caregiving relationship. Those points distinguish it from PTSD, which is typically a discrete trauma. You were robbed, you were in a car accident, you were in combat, okay? Complex trauma is chronic, not discrete. It occurs early in development, and what makes it so damaging is that it occurs within the caregiving relationship. So just very briefly, I'm not going to belabor the point. The attachment system gets activated when you are distressed and you want to gravitate toward your primary caregiver, who, provides safety, security, and comfort. When you're threatened, the fight, flight, freeze system gets activated. So what happens if the source of threat is your primary caregiver? Well, the attachment system gets activated, so you want to get closer to them. And the fight, flight, freeze system gets activated, so you want to get away from them, right? Because they're a danger. And it's kind of like driving your car with your foot on the brake and the gas at the same time. Systems break down. Okay? And the areas that may be affected by chronic early maltreatment that occurs within a caregiving relationship, complex trauma, our attachment, emotional regulation, behavioral regulation, cognition, biology, defensive functions, and self-concept. So those also are considerations. Okay, I think I've described this, right? The difference between, I call it simple trauma, PTSD, versus complex trauma. So I'm not going to go through that. The basic model, as I've described, 3 sessions. And, you know, this is a balance. You want to engage in a comprehensive assessment, but in an economical, from a time point of view, economical manner. And I found that this 3-session model is quite effective in developing a good treatment plan, whether the child has experienced early trauma, whether they have attention deficit hyperactivity disorder, depression, anxiety, what have you. I use the same basic approach for assessment. So as I mentioned, you want to review all of the records, and I've described this. By the way, all the tests and questionnaires that I will mention or mention during today are all tests and questionnaires that you can use, provided you have a master's degree. It's actually not your license that controls whether you can or can't use a psychometric instrument. It's the test publisher. But all the ones I'm going to mention can be used as long as you have a master's degree in, you know, the mental health field. So let's move on. Oops. Okay, so we've covered this. A very important area to at least consider is alcohol-related neurodevelopmental disorder. In other words, prenatal exposure to some toxin like alcohol, crack, drugs, etc. The fetal alcohol spectrum disorders continuum has FAS at one end, where you've got all the facial cranial manifestations and abnormalities. At the other end is ARND, where you have the criteria for that would be definite or probable prenatal exposure, early developmental delays or low birth weight, or later developmental delays, and cognitive impairment. So this is where, for example, in all my assessments, I use the brief, as I mentioned. I also use the Vineland adaptive behavior scales that measures an individual's developmental functioning. And so between those and history, I would have some idea whether there has been prenatal exposure and to what extent, and has it created any, any cognitive impairments that we need to consider. Because, for example, the impulsivity associated with ADHD is treated very differently than the impulsivity caused by alcohol-related neurodevelopmental disorder. Okay? So the impulsivity with ADHD can be treated with different medications, stimulants, for example. The impulsivity caused by ARND, stimulants will make that worse because it's a different part of the brain that's affected. ADHD is largely call it a disorder of an immature prefrontal cortex. The impulsivity associated with prenatal exposure to alcohol is largely a function of the damage done to the limbic system. So different medications are appropriate, things like clonidine, 10X, Intuniv, blood pressure type medications that are helpful in that regard. As you know, when children age, your brain isn't fully integrated till the early 20s. So very often the symptoms of ADHD begin to decrease as somebody gets older. the impulsivity associated with AR&D doesn't change with age. Okay, so these are important distinctions. Different tests and questionnaires I mentioned. This is a list of kind of typical ones that I use. As I mentioned, all of them you can get from the test publisher if you have a master's degree. I like my criteria. You may have other criteria for tests. I like these tests for a couple of reasons. First of all, they're reliable and valid, and that should, apply to any test that you use. Second of all, there are different versions, like parent and teacher version or parent and child and teacher version. Very important to get similar information from different domains. So, for example, a lot of families I see where there's impulsivity, the brief indicates cognitive impairments, and if the profile on the brief is similar for the parent version and the teacher version, that would suggest the difficulties identified are more kind of hardware related, brain related. If the profiles are dramatically different, well, that would suggest that the impulsivity and the problems identified are more of an emotional and psychological nature. And of course, you treat those differently. Emotional and psychological issues can be treated and remediated. Issues that have to do with brain damage, you can't fix that. What you do for those kinds of difficulties is put in place external structures to make up for the internal deficit. That's the principle. What does that look like? Well, a good example, you don't have to answer this, but in your home with your family, who does the grocery shopping? Do they make a list? Or do you make a list when you go grocery shopping? Why? And when I go through that with parents, the typical answer is, one of them does the grocery shopping. Do you make a list? Yeah. Why? So I don't forget. Exactly. You don't have perfect memory. So to make up for your lack of perfect memory, you make a list. And now your internal deficit is no longer a problem because you've got an external structure in place that makes up for that. Okay, so that's the kind of thing we want to put in place for kids, for example, who have brain damage associated with prenatal exposure to alcohol. Often what I wind up suggesting with parents is that they create little, for example, around chores, little chore cards, okay? Because kids with ARND may have trouble remembering things, may have trouble remembering sequences and sequencing, okay? So with the child, you make up a little card that lists all of the different things they have to do. For example, if one of their chores is cleaning the bathroom, the card might say, get a sponge, get the cleaner, wet the sponge, put the cleaner in the sink, wipe the sink down, wash the cleaner out of the sink, okay? In that kind of detail. And the detail needs to be what is relevant for the particular child for them to accomplish what you want them to. And what I will say to a parent, so you make the card up with the child, maybe for a young kid, you put pictures. You do that with the child a number of times, a number being probably more than 10. And then when that seems to be going well, you just watch them for a number of times. And when they seem to be able to do it, then later when it's time for them to clean the bathroom, you just give them a chore card. And that makes up for their internal deficit. And that then becomes a skill that they can use later when they have other things they need to do, and they can start doing that for themselves. Okay? So these are some of the tests and questionnaires that I use. I've mentioned some of them: the Vineland, the brief, child behavior checklist, etc. And I find them particularly helpful. Okay. All right. Whoops, went too far ahead. Okay, so actually here is a good place to pause, because next I'm going to give you an overview of dyadic developmental psychotherapy. So any particular questions that have popped up about the assessment before I move on?
Chat in any questions you might have for Dr. Becker-Weidman at this point.
No? Okay, that's fine. If you do, just put them in the chat, and I'll, at a later pause, I'll get to them.
I'm sorry. There is a question. Are these all recommended or just some? Kelly, if you can clarify, are you talking about the assessment? The set of specific tests? Okay, yeah. Any issues you see with cultural relatability and these specific tests? So yeah, and then so the first question is so the list of screening tools I think you see here. Just a reminder for our audience, the slides will be available on our website within a couple of days, so you can always go back and refer to the slides, and that list will be available. But yeah, I guess the question around this list, is this your comprehensive list? Are there others that you would also include in your assessment?
Yeah, good question. So I always use the child behavior checklist, the parent version, the teacher version, and the youth version if the child is old enough. If there are potential issues of trauma, then I use the trauma symptom checklist for young children. Or if the child is older, the trauma symptom checklist. If it's a oppositional defiant disorder or depression case, there's no history of trauma, I don't bother with those. I have something I developed, a symptom checklist screener. It lists, I think if I remember right, it's about 81 behaviors down the side of the page, several pages. And across the top of the page, it lists different ages, 0 to 2, 3 to 5, et cetera, up to about 18. And the parents fill that out, and they just check, was the behavior present, and if so, at what ages? It follows the DSM-5 criteria behaviors for ADHD, oppositional defiant disorder, depression, anxiety, and I think some substance dependence issues. I just developed that. I just wrote them out. If you're interested, email me, and I can email you an electronic copy that you're free to use. So that one is mine. Behavior rating inventory of executive function, I always use that. Parent and teacher version. Vineland adaptive behavior scales. Most of the time, not always, but most of the time I use that. Sensory profile, most of the time. Developmental history form, I always use that because I want to get information about early development. Parent stress index, I pretty much use that all the time because,
And we had actually, Art, with that, we had a specific question about that. If you could just simply say a little bit more, can you elaborate on the parental stress index and how you use it and what it's for?
Oh, yeah, parent stress index, there are two broad domains in it. One is child specific. So if a family has 3 or 4 kids, those first scales might be different for each kid. The second set of scales are more parent related and are probably going to be the same across the board. I use that because, well, let me put it this way. Parents are much more important than therapists in affecting a child's behavior. Okay, this is my view, right? I might see a family or a child, 1 or 2 hours a week. The child lives with the parents who has the bigger influence. So their level of stress and distress and their difficulties with the particular child, I find particularly informative as I develop a treatment plan. And it may make a difference, for example, in whether I'm seeing, say, the parents with the child around the child's concerns or issues, or whether I'm seeing the parents alone about parenting, or whether I'm seeing the parents alone because there's some issues identified on the PSI, Parent Stress Index, that maybe we need to resolve before we begin treatment. Okay, so for example, I'm sure you've all had this experience. Two things. First of all, some parents think what they really want is, you probably heard this expression, they want drive-by therapy. I'm going to drive up to your office, drop my kid off, and 45 minutes later, I'm going to get a new kid. This is why the assessment is important, because if they don't understand the assessment, talking about family treatment when they're expecting drive-by therapy won't make any sense to them. So that's why in that third meeting, we talk about the assessment, what I think's going on, answer their questions, make sure they're on board before I talk about what they're going to do. The second thing is you don't want to involve the child in sessions if you think the parents are going to be shaming, blaming, harsh, critical, or punitive. I'm sure we've all had this experience, where we haven't maybe prepared sufficiently. We have a family meeting and the parent, I guess, seems to believe or think the point of the session is to say, let me tell you, doctor, what my daughter did last night. They've got the finger going and they're telling, and that's not going to be helpful because, as you know, in order to implement good and effective trauma treatment, everybody has to feel safe, comfortable, and secure emotionally and psychologically. And if the session is about, what you did last night and what a bad kid you are, that you can't do trauma treatment. Did that answer your question about the PSI?
And yes, she says yes. Thank you.
Okay.
So yeah.
Okay, good. Okay. Any other questions about assessment before I move on to talking about DDP?
Okay. Doesn't look like any
Okay.
at this point.
Okay, so just to be clear, I'm giving you an overview of this approach. What I try to do is condense into about an hour what ordinarily would be a 48-hour, 6-day training program, okay? So this is going to be kind of a high-level overview of some of the important principles, okay? No, we're doing okay with time. So first, a couple of general principles. You have to form an alliance with your client. And in my mind, my client is the family and the parents. Like I said earlier, who has the biggest influence on the child? It is the parents. Okay, so if you're going to be doing good treatment around complex trauma, you need to develop an alliance with the primary caregivers. And you need an alliance if you're going to create a secure base, which is necessary for a healthy and secure attachment. Once you've kind of begun to develop the secure base, then you need to maintain it. And then you can engage in exploration, which leads to integration. One of the major symptoms, for lack of a better term, of trauma is dissociation and a splitting off of explicit memory from implicit memory. And so integration is one of the major healing elements of good trauma treatment. And integration leads to healing, and that strengthens your alliance, lets you do further exploration, deeper exploration, leads to further integration. In other words, this is a iterative process. I use the phrase, these are the phases of treatment, not stages, right? Eric Erickson talked about stages of treatment, and right, once you get to the next one, you don't go back. I describe this as phases because it's repetitive. Like, well, what else has phases? The moon, right? The moon has phases. It keeps repeating itself. And the other important idea around phases is that even though the moon goes through phases, quarter moon, half moon, new moon, etc., the entire moon is always there. All of these elements are always present. It's just at certain points in treatment, different phases are highlighted. Okay. Okay, you move on. Again, a couple of basic principles. Being an ACE therapist, meaning being accepting, curious, and developing empathy is a core element. Okay. What you accept is the person's experience. Now, the behavior may be unacceptable, but their experiences, why did the kid, why did the girl bite her mother? Well, because she was angry. Okay. The biting may not be acceptable, but her being angry is acceptable. Being curious, not curious like I'm going to get the truth out of you, but curious, demonstrating that I'm really interested in you. And that has in and of itself a healing element. You're only interested in people that you care about and that you value. So you as the professional being curious and encouraging the caregiver to be curious is therapeutic in and of itself. And out of that curiosity, that's how you develop empathy. Oh, now I see why you had that tantrum. You thought blah, blah, blah. Okay. That's often what I find in a session that we get to. Oh, now I understand. Now I see why you threw that at your brother because you thought he was going to do X. See, and then this is my view. You may feel differently. My view is it's really tough to stop behavior. It's much easier to redirect it. And once you get empathy, then you can redirect it. So, oh, you were angry at your brother, you threw, a toy at him. Now we can talk about, well, what else might you do when you are upset with your brother? Maybe a better example, I was talking with a parent a couple of weeks ago, referred by the social service department. He had, abused his son. He'd literally beaten him with a coat hanger, okay? I think we'd all agree that's not okay. And of course, he came in expecting to get a lecture about what a bad parent he was and, how awful he was because of what he did. But what we began talking about is, well, what happened? And he described his son talked back to him. He had told his son to do something. His son back talked him. He got angry. That's not okay. So so you were upset with your son. What about that was upsetting for you? That's curious. And what we got to there was, my son has to respect me. Okay, and got to, again, being curious about that, me being curious about that. Why does that matter? And, it's interesting, he got really indignant. What do you mean, why does that matter? If he doesn't learn to be respectful to me, he's not going to respect teachers, police officers, and the people, that he works for, and he's not going to be successful. So that allowed me to say, oh, oh, so you think your kid could really be successful if he just sort of gets this idea of respect into his head. And the guy said, yeah, that's exactly right. Okay, so let's figure out, and this is what it led to, let's figure out other ways to help your son learn how to be respectful other than beating him with a coat hanger. So his intention was fine. Nothing wrong with wanting your kid to learn how to be respectful. It was the method, the behavior that was unacceptable. Once you can get to what sort of the underlying driver of the behavior is, then it's much easier to say, well, let's try to figure out a different, a better behavior that isn't going to get you in trouble or something like that, okay? It's about the relationship. I talk with parents a lot about that, that we focus on the relationship. I have a phrase I'll get to later. I describe it as it's about connections, not compliance. And then we can talk a little more about, it's not that compliance isn't important. The way you get compliance is through an emotionally meaningful connection with your child so that they value your approval and are uncomfortable when you don't approve of them. And that they'll carry away. So even when you turn your back, they'll do the right thing. Listen, if I hold a gun to somebody's head, I can make them do anything, but the moment I walk away, they're not going to continue with that. Good. When my older daughter was applying to graduate school in clinical psychology, for I'm sure a lot of you had to write an essay. Why do you want to be a psychologist? And she described how my mom and dad are in the helping field. Growing up, we always talked about things. And then she wrote this little vignette. She said, I remember being 4 years old, running down the hallway, screaming, no, not another discussion, just put me in timeout. Okay. And what that illustrates is, whenever we said to our kids, come here, we have to have a discussion, that meant we weren't happy with what they did. And Emily, in effect, was saying, our displeasure with her made her so uncomfortable, she would prefer physical discipline to our displeasure. That's what you're trying to achieve. It's about connections, not compliance. You'll get compliance through connections. Okay. Very important. While psychoeducational presentations can have a place later in treatment, once you have a strong alliance, once the parents are really connected with you, early in treatment, I don't think that's such a good idea. You'll do better early in treatment, asking questions, leading them where you want them to go, not telling them, because, just because the client is nodding their head, that doesn't mean they agree with you or even understand. One of the things I often say to parents, somewhat related to this, when you ask your child to do something, don't ask, okay, or you got it, or you understand. Just because they say yes or nod their head doesn't mean they do. We all know when someone in authority is telling us something, you do better nodding your head than shaking your head, right? Better to ask your child after you ask them to do something, now tell me what you're going to do. Because then you'll know, do they really understand what you said or not? Okay. And the same with parents. I don't use psychoeducational presentations about attachment or trauma or behavior management or any of that stuff until way later in treatment. I ask questions to lead them where I'd like them to go. And the advantage of that is then you sort of are moving in treatment at their pace, okay? Because if Things will go slowly if they're having difficulty with the concepts, or things will go really quickly if they don't. So you move at their pace, not necessarily your pace. Okay. There we go. Okay, a few more principles. We talked about the importance of assessment that determines treatment. Parents are the keystone. This is why, to back up a moment to the assessment, this is why my first meeting is with the parents, not the child, right? In a lot of clinics, a parent calls up, they want their child seen, they bring their kid in, and the first one to be seen is the child. And I think that gives the, my opinion, that gives the wrong message. As I've described, parents are really the keystone. They are the more salient ones in this sort of whole picture. So I want to underscore that by meeting with them first, before I meet with the child in the assessment. And it makes them, helps them understand later why quite often treatment is family-based, and why I may meet with the parents 1, 2, 3, a dozen times before we even begin the family session. Because as I mentioned earlier, you can't do treatment if the parents are going to be shaming, blaming, harsh, critical, or punitive. So they're, they're really important. I want to, if it's a 2-parent family or 2 caregivers, I want to meet with both. And I'm sure you've all had this experience. You get the phone call. Usually it's a mother. I'd like to bring my son in. And if I say, okay, I'd like to, meet first with you and your partner, your husband, whoever. And I'm sure often you hear, oh, no, my partner's really busy. They're working. I don't know that they can come in. And what I'll tell you, if you don't get them into that first meeting, you're probably never going to see them. So when I get that, oh, no, she is really busy. Tough job. I don't know. She can't come, but I'll take care of it. My response to that is, oh, okay, I tell you what, give me her phone number. I'll call her directly and I'll work out the schedule around her schedule. And what I find is even if I've been told, no, he or she thinks that this counseling is ridiculous, it's stupid, they're much nicer to me than their partner. And when I call them up and say, I'd like to meet with you and your partner, what works for you? Sometimes I'll hear, well, my partner can give you the story. You don't need me. And I'll say, no, you're important. I want to hear what you think as well. And so most of the time I get both of them in. And then they both come in for that third meeting to go over the assessment and talk about treatment. Okay, 2 concepts in DDP, pace and place. Your job is to be playful, accepting, curious, and have empathy. I've talked about that. Parents' job is to create a healing place. Remember, they're the important one. Playful, loving, accepting, curious, and developing empathy. Playful part, that's really a function of your personality, how you use that. That can be useful in engaging people or diffusing situations. So I'll give you 2 examples. Very often, the first 1 or 2 family meetings. So typically, after the assessment, I might meet with the parents once, 2, 3, maybe a dozen times to talk about parenting and parenting issues and things like that. But the first couple of times when we meet with the family, and the way those sessions work is first I meet with the parents. How did the week go? What worked, what didn't work, issues, concerns, when we're done with that, then the child comes in, we all meet, and then at the end, I might spend a couple of minutes with the parents debriefing. So even say, for example, a couple of children I see who have notable anxiety disorders. And so I've worked with them around, CBT and stress and anxiety management stuff, deep breathing, guided imagery and all that. But when I do those pieces, or helping them learn about them, I always have the parent there. So I'm sort of educating the child or teaching the child with the parent there, so the parent gets it, so that at the end I can say, now what I'd like you to do is practice with your child twice a day until it becomes muscle memory. Okay, so 2 examples of the playful piece. Often in the first 1 or 2 meetings with the family, I just want the child to feel comfortable and that this is okay and maybe even fun. In other words, it's not going to be about what you did last week and, we're not going to do that. I like card tricks. I like magic. So I do that with kids. You have to find what you like to do. I have a colleague, she's an art therapist. She does a lot of media stuff that is, it's amazing. I couldn't do it, but she's great at it. And that engages kids. Okay? So that games, riddles. I like riddles. The key is I like them, and I think then kids like them. So that's one. Another example of diffusing a situation. I was meeting with a family, and it was the adoptive mother, the girl who was about 12, and the adoptive father. And I don't remember what I actually said, but I said something that really got her angry. And to go on with the example, if you're offended by profanity, this is kind of a warning, plug your ears at this point. All of a sudden, she got really angry, and she starts, it's the mother, the girl, the father sitting on the couch. I'm sitting across from them. She starts screaming at me, and the spit's coming out of her mouth, and she's going, "Fuck you, you fucker!" And she's going on and on like that. There's a spit's coming out of her mouth, and I could see, and this didn't go on that long. It was like maybe 15, 20 seconds, which felt like a long time. And you can see her parents were getting ready to intervene. And of course, you can imagine what they were going to say. Lynette, calm down, stop it, don't talk to the doctor that way. And do you think that would have been helpful? Probably not. What I just came to me, what I said to her is, I looked at her right in the eye, and I said, that's Dr. And so did her parents. And that diffused. So being playful can be helpful, both in engaging your client, but also in diffusing potentially difficult situations. Okay. All right. Oh, good. We're doing okay with time. There we go. Okay, a few more general principles. We've covered these. Causes, not symptoms. That's what we focus on. Kind attributions. What do I mean by that? Words matter. How you frame things make a big difference. So by kind attributions, what I'm referring to is finding a way to describe what's going on in a non-pejorative, non-shaming, blaming, or punitive manner. So for example, a child takes things that aren't theirs from their parents, from kids at school, from their siblings, and parents will describe that as, my child steals. Or they may even go further and say, my kid's a thief. Now, I don't know about you, but I don't feel very warm or fuzzy or even that I like thieves very much. But if you've gotten some history, you may find, or it may be, that what you're actually seeing is a lack of trust. It doesn't occur to, and I've had this discussion with parents, oh, maybe it is that because of these earlier experiences, your child doesn't believe you're going to be helpful. So when she needs $2 for lunch at school, it doesn't occur to her to ask you, so she goes and takes it out of your wallet, right? Because it's a lack of trust. So when you see your child as having been so hurt by others that he or she can't or doesn't trust adults, you're going to feel very differently than if you see the child as a thief. Okay. And as a clinician, it's important that you recognize all behavior is adaptive. So often what we describe as a symptom is merely adaptive behavior that is in the wrong environment and is no longer adaptive. What would I mean by that? For example, if I've been in a neglectful home for the first several years of my life, 2, 3, 4, and often I didn't have enough to eat. And I learned, dumpsters have food, garbage cans. I can ask people for food when there is food. I better, eat while I can, or put it in my pocket or something for later. And that's smart. That's adaptive. Now you put me in your home. You have a good home, and you've got lots of food, 3 meals a day and snacks. And now all of a sudden I've got a symptom. I'm hiding food under my pillow. When you put food in front of me, I'm stuffing myself, right? It was adaptive behavior. It's not now. So thinking of it in those terms allows you to feel differently and then act differently. Okay, so that becomes important. I already described connections, not compliance. Developmental age. This is why I use the Vineland adaptive behavior scales. I did a study several years ago. If you're interested, I think it was published in Child Welfare. Email me, I'll send you a copy. It was just a descriptive study looking at a group of children who met the DSM criteria for reactive attachment disorder and the clinical construct complex trauma, and looking at their scores on the Vineland adaptive behavior scales. And what we found is that they were developmentally several years younger than their chronological age. If I remember, I think the average gap was like 4 or 5 years. And why is that important? Because we treat people where they are developmentally. So when you have a 9-year-old who maybe functions more like a 4-year-old, you need to think of them like a 4-year-old. Because if you were to ask a 4-year-old to do all the things that a 9-year-old could do, the 4-year-old is going to be very frustrated. You're going to be annoyed and frustrated, and this is going to spiral downward pretty quickly. Okay. So whereas the child developmentally, we treat them that way. I often suggest to parents, particularly if they have, like a 10, 12, 14-year-old, because that can be hard to remember that their 12-year-old really developmentally is more like a 7-year-old. What I've suggested is, I ask them, do you like sports? Who's your favorite sports team? Whoever it is. What I'd like you to do is get a couple of jerseys for that team with that number on the jersey. So, your child will be happy to wear the Bills jersey because you like the Bills, and it has the number 7 on it, and that's a reminder to you, oh yeah, she is more like a 7-year-old than a 12-year-old. So developmental age, not chronological age. And then another general principle is because complex trauma is so insidious and affects so many domains of functioning, treatment requires more time together, parent and child, not parallel play, not one reads the newspaper and one plays video games, but interacting together. Okay. And the last part I have there is I tried to boil down parenting to a very simple model. First, you do it for the child and make it enjoyable. Then you do it with the child and make it fun. And then the child can do it independently. Okay? So what's an example? An example would be you have a 7-year-old with bad hygiene. And they don't brush their teeth, they don't bathe well. So what would you do? Well, you can, at that point, well, let me go back. For those of you who've had young children, you know, from infancy or toddler on up, once they grow a tooth or two, do you hand them a toothbrush, a tube of toothpaste, and say, get in the bathroom and brush that tooth? No. You do it for them. And you brush their teeth. And at some point, the toddler, you know, maybe middle, late toddlerhood, will grab the toothbrush and say, me do it. And they do it, and they do a crummy job. But you don't yell at them and say, that's awful, you know. You then say, oh, let me do finishing touches. So now you're doing it with them. And after a while, they do a good job. So you do it for them, you do it with them, then they can do it independently. So with the 8-year-old with bad hygiene, you know, maybe you don't want to brush their teeth for them, but maybe what you do is after breakfast, say, okay, it's time for us to brush our teeth. Again, it's about doing it together, not time for you to brush your teeth. And you go in the bathroom with them and you both brush your teeth. And then you make it fun. Maybe you say, hey, brush my teeth. Hey, I'm going to brush your teeth. Make it a game. You make it fun. And eventually they'll be able to do it independently. Related to that is, I think, really important concept, which is the difference between can't and won't. Quite often parents will say, you know, my child, for example, won't brush his teeth. Well, again, this is a good example of how you describe something affects how you feel and what you do. If you ask me to do something and I won't do it for you, you may get annoyed. You probably won't like me. On the other hand, if you ask me to do something and you say, oh, wait a minute, Art doesn't know, Art can't do that. He doesn't know how to do that. What are you going to do? You're going to teach me. You're going to show me. You're going to help me. The can't, right, brings us together. The won't pushes us apart. Okay? So that's very important with parents to help them get that distinction. And I tell parents, you know what? You can never go wrong assuming your child can't do something. You know, even if the teenager is just yanking your chain, so you do it with them, and eventually you can say, no, you know, stop. I can do it. Okay, it brings you together. It doesn't push you apart. Okay, let's go here. There we go. So we've talked about this. Parents really are central to treatment. Okay, there we go. So you need to remember they are the most important ones. And, you know, one way to think about it, whatever you'd like the parents to do with the child, you need to do with the parents. So if you think, for example, the parents are not reflective enough, you would want to be more reflective with the parents. If you think they're not sensitive enough, you want to go out of your way to be sensitive to them, to kind of do with them or to them what you'd like them to do with or to their child. And in my clinical experience, the best predictor of treatment outcome is not how disturbed is this kid. It's really parent capacity. Their level of insightfulness, their ability to be reflective, okay, their own attachment history, all of those kinds of things. It's up here. Okay. Okay, so I already talked about this. So all of these issues are, and again, in the assessment, when I'm meeting with the parents that first time, I'm getting kind of an informal reading of how insightful are they? What's their pattern of attachment? How sensitive are they? What's their reflective capacity? And what's their level of commitment to this child? So as an example of how would I informally assess insightfulness? Usually about a third into the interview with the parents, they've already described all the things their kid does and, you know, all of that. I ask each caregiver, of everything the child does, what most gets under your skin? What do you find most bothersome? And very often it's different for each caregiver. And then I ask, so what is it about that you find more bothersome than these other things? So it matters whether they have a good answer, or if their answer is something like, well, what do you mean? That's just terrible what the kid does. Okay. So an example, I was meeting with a single mom. She'd adopted twins, fraternal twins, boy and a girl. They were about 7 years old. And, you know, I'd asked her then, of all the things your kids do, the two of them, what do you find most bothersome? And she thought about it and said, you know, my daughter, I've told her 1,000 times, don't, at the dinner table, don't chew with your mouth open, don't talk with your mouth full. She does it all the time, it drives me nuts. And then I said, or asked her, so what is it about that you find more bothersome than your son, who you described as when he gets angry, breaks things? You said he broke a cocktail table, he broke a lamp, he smashed a mirror. What is it about your daughter? You know, the chewing with her mouth full or open that's so bothersome? And she thought about it and said, I don't know, but I think maybe, she said, I grew up in rural South Carolina, and for my parents, manners were very, very important. We had to be respectful, we had to use good manners all the time. So I don't know, maybe something like that. See, that's a great answer. That shows a reasonable degree of insightfulness. So the questions like that I kind of get to in that first meeting with the parent, just to give me kind of an informal reading on some of these important elements. Okay. It's up a bit. Okay, effective treatment. These are the goals of treatment generally: resolving these early losses, developing trust in their primary caregiver, the modulation of affect. All of these are essentially goals of attachment-focused treatment. Mm-hmm. Let's see. Skip ahead just a little bit. A few basics. Most of the time, I schedule 2-hour sessions because that gives me enough time to meet with the caregivers. How did the week go? What worked? What didn't work? Et cetera, et cetera. Then time with the family, and then a little bit at the end. And then, you know, I do find as we go through treatment, often an hour and a half or so, an hour and 15 minutes winds up being enough. But early in treatment, I find it's helpful to do that. That way, I don't feel rushed, and we have plenty of time to really, you know, peel back the layers of the onion, so to speak. Everybody who's involved in the child's life in a significant way should be included. The primary caregivers, which may be, you know, a dad and a grandmother and grandfather, foster parents. If the child's in residential treatment, it may involve the primary caregivers and whoever is the primary youth worker for the child in the residential program. Okay. And let's see, let me skip ahead a little bit more, a couple things I do want to make sure we get a chance to cover. There are different components of treatment. I'm not going to go through each one of them because we just don't have time, but I've got them listed here for you. And let's call up this slide. Here we go. So I've got 14 components of DDP. You don't really use these discrete. I have these listed more for teaching purposes. You know, you're not in the session going to say, well, I think this requires a number 1, 6, and 10. Okay, merely for teaching purposes that these are major components of this approach. We talked about pace and place. We talked about reflective capacity, commitment, use of self in terms of, you know, playfulness. So anyway, just it's important to recognize that there are these different components of treatment. Okay. And lastly, just want to go to this slide here. I talked about the phases of treatment. So the process, as I mentioned, it really is iterative. You begin with an alliance that creates the secure base that allows for exploration, integration, and healing that strengthens the alliance and lets you. So you often come back to the same issue or theme again and again and again, but each time going a little bit deeper. Okay? And for some families, if the quote, only thing you did was develop a therapeutic alliance with the caregivers, okay, that may be in itself therapeutic and good enough. Okay, so I think it's important that you not think, well, I got to get this alliance going so I can get to the good stuff, exploration and integration. No, the alliance and creating a secure base kind of is the good stuff, and you need that. Probably here's a good place to pause for questions, anything that's on your mind, anything you'd like me to elaborate on. As I said, I kind of wish we had a lot more time to talk about this stuff in more detail, but I think this gives you a okay overview of some of the basic principles of DDP, the assessment, and how that all fits together. So what questions do you have? Anything you'd like me to answer, or anything you'd like me to elaborate, spend a little more time talking about?
Coming in, so there's a few. Okay. Yeah. Oh, okay. Oh, well, this is a very basic question. It has to do with that alliance and kind of engagement. Have you had a parent who attended sessions but was not willing or interested in engaging in the process? And I think that's owing to your earlier point about sort of drive-by, right? So what do you do to address that drive-by approach and getting folks to understand and move past that?
This is where the assessment's important because, they want to do drive-by. And when I say, well, I always begin with a thorough assessment because there are different approaches for different underlying conditions. So first I want to meet with you and your partner, so they come in, okay, yeah, he's got to get some information. And then I get a lot of information and talk with them. And then they fill out all these tests and questionnaires and get to school too, and they get them back to me. Then they meet with their child. And then when I meet with them in that third meeting, remember the first part of the meeting, I'm describing my assessment. So they may be thinking, I just have a rotten kid and I'm going to drop him off and you're going to fix him. But when I describe my clinical formulation and go through all the tests and questionnaires and how that educates me about my clinical formulation and all the things they've told me and what I make of that, they kind of begin to come on board. And I don't talk about treatment until they see things the way I do. Because, if they're thinking, I just have a bad kid and you're going to fix him, my saying, I'm going to meet with you first to talk about parenting, he's going to go, what? What are you talking about? So the assessment, I stick with the assessment until I can see they get it and they can agree with it.
Yeah.
And then I talk about treatment. And so again, I'm describing what maybe I meet with you a couple times about parenting issues, then we'll involve your kid, blah, blah, blah. So that's where they're going to get on board. That's why I think to be real blunt about it, it's not unusual halfway through that first meeting with the parents for me to say, to myself, I said, yeah, I know what's going on. I know what the assessment is. I know what I'm going to recommend. But I go through the entire process anyway, because I want to get the information, but also it makes it much more credible when I say, here's what's going on and here's what we should do about it.
Yeah.
So that's how you avoid that. That's how you get people on board.
That's and actually it raises actually a question that I had, because you mentioned earlier that you don't do psychoeducation till later, but in my head, I see you doing psychoeducation in a very different way that is kind of reframing things, right? I think, as you're saying, like you're reframing things as relational, and so on and so forth. But could you say a little bit more about that? Because I do see those things as psychoeducation, exactly as you're saying, right? Seeing it as a family relational issue, not just a rotten child issue.
Right.
So yeah, could you say a little bit more about that?
Yeah,
what might that psychoeducation look like later?
Yeah, so when I say not psychoeducation, I don't start out when we're meeting, say, around parenting stuff to say, well, here's what I want you to do, A, B, C. When kids have experienced complex trauma, here's how it can affect attachment and behavioral regulation, emotional regulation. Here are some things you can do. I don't do that. I would be talking about. So you said your kid takes money out of your wallet. What do you think makes your kid do that? I don't know. He's a thief. Okay, but you described some of his earlier experiences before he came to you. Could there be any connections between the two? Well, I don't know. No one really took care of him. He was kind of on his own. Oh, well, if that's true, he was kind of really on his own. How would that affect his perception of how much he can count on somebody like you? And then, gee, I guess he's not going to really trust me very much, is he? Yeah, I think you're right. See, that's what I want to get to. Not my idea, but yes, I think you're right. He probably doesn't trust you very much. And if he doesn't trust you, why would he ask you for anything? Oh, yeah. Okay. Yeah, good point. So that's what I mean. Now, later in treatment, once we've got a good alliance, I'm very direct. I'll say, like I saw a film the other day, the mother said, oh, I forget what her son did. He's like 8 years old. She said, I had him write 30 times, sentences. I forget what they were. Anyway, we've been meeting for a while. I said, don't do that. And let me explain why. I understand if I understand it, you're trying to get him to understand why what he did was wrong. She says, yes, absolutely. I don't think it's going to sink in. I don't think it's going to make a difference because how many times have you done that? And she said, yeah, we do it a lot. It's not working. Stop that. It puts a wedge between you. And then I talked about, this is what I'd rather you do. And what I talked about with her then and told her, what I'd rather you do is think about, something with her, anyway, what I'd rather you focus on is how he hurt his relationship with you and what you would like him to do that would make you feel better. So it's not about punishment, because punishment is about retribution. It's about how to repair the relationship. So I said, could be anything. Could be, draw a picture I can bring to work. If that would make you feel better, have him do that. If it's, I'd like you to clean the kitchen sink because I don't like doing that, and that would make you feel better, good, do that. Have him do something to fix the relationship, not right. So anyway, that's what I mean. But later in treatment, I'm very direct. Do that, don't do that.
Okay. I see more questions coming in around that issue of, having parents who might be reluctant or resistant or having a difficult time engaging in the treatment. So, but unfortunately, we are short on time. So what I'm going to suggest is that at 1:29, I know folks are already logging off. A couple of things. One is if you, as you come off of the webinar, you will get a survey. Please, please, please fill out that survey. Let us know. And we had a discussion with Art before this, and he's very open and very willing to think about more offerings. And so if you have more topics that you'd like Dr. Becker-Weidman to address, please put those in the survey and let us know. We can pass those along. I also want to take this moment as we're finishing up to thank Dr. Arthur Becker-Weidman. We're at the end for his time and his presentation. I had a ton of questions that I wanted to ask them. I had to put on hold because of the time, but this was rich and helpful. It integrated so many things that in many ways I've thought of often, but sort of nicely summarized with this approach. In many ways, I kind of see a lot of what you're talking about, very practical, very hands-on, and thinking a lot about building attachment through, obviously through the various interventions. So it was very enlightening for me. I hope it was for other folks. So again, once again, I'd like you to thank Arthur Becker-Weidman for his presentation. Please complete the survey. Oh, and Art, if you can, just advance the slide to the end. Just want to mention, we do have a couple of additional slides, or excuse me, a couple of presentations coming up very soon. And I will go to the CTAC website. Apologies, they're not up. It's okay though. We do have a couple coming up that you may be interested in. We're going to have a conversation with Dr. Tony featuring Nan Henderson on resiliency in children and youth. And actually we'll also have a training for resiliency, helping children and youth grow in the face of adversity. So we have a couple of additional offerings coming up in the near future on similar topics. Again, addressing the needs of children who've been through adversity and trauma in their lives, and helping them build resilience. So please join us when you can on those upcoming webinar offerings. Again, thank you all for participating in today's webinar. As I also mentioned, the video of the recording of this session, the slides will be up on the website. And as Dr. Becker-Weidman already mentioned, the info, oh, Art, a couple of folks did ask, I put in the website address. Can they find, okay, so they can contact you through that website address?
Yeah, through the, my email is on there, and then on the bottom of the slides, it lists my phone number, and, feel free to call or email, either one.
Okay. And I have to tell you, and I told Art this earlier, we very rarely get that kind of offer. So feel free to take advantage of it and follow up with Dr. Becker-Weidman if you want to reach out to him and get more information and more consultation. Again, thank you all. And thank you, Dr. Becker-Weidman, for a wonderful presentation.
Thank you. I appreciate it. I enjoyed it. I hope everybody else did.
Take care, everyone.
Bye-bye.